Evening, ma'am.
Good evening.
I'll be presenting a case of a 65-year-old female who was working as a staff nurse and is currently retired, residing from Malur. So informant was herself and her daughter, and the information was reliable. She came with chief complaints of difficulty in using objects since 3 years. History of presenting illness: premorbidly, the patient used to wake up at around 6 a.m., prepared breakfast, and used to go to the hospital by 7 a.m. Comes back by 3 p.m. and prepares lunch and eats. Sleeps for about 1 to 2 hours, following which she goes to a temple, prepares dinner by 8 p.m. and then sleeps by 10 p.m. In the hospital, she attends rounds, prepares duty roster, indents medication, and supervises work in the hospital. So, patient was apparently all right 3 years ago when and was performing her daily activities when she initially noticed difficulty in putting the badge over her dress. Initially, she was able to identify the badge, hold it tightly, and insert the pin into the dress. But because of difficulty in pinning and unpinning the badge, she stopped wearing the badge. Following that, she noticed a multiple similar problems like difficulty in knotting and unknotting a petticoat. And because of inability to unknot the petticoat, she had to use the scissors to remove the knot. She was also able to make pleats in the sari symmetrically, but however, she is noticing difficulty over the past 2 years, such that she used to ask her daughter for assistance, and since 1 year she stopped wearing sari and is only wearing gown. Patient also complains of difficulty in putting the paste over the brush. The difficulty is described as that she squeezes excess amount of paste, brushes only the front part of the teeth, and doesn't manipulate the brush to the sides of the teeth. Patient also complains of difficulty in opening and closing jar lid such that the patient holds it very tight and moves the jar lid clockwise and anti-clockwise manner in a very clumsy manner. Also, she complains of difficulty in opening the pen cap. With the change in pattern of holding the pen caps, is that initially she was holding the pen with 2 fingers near the nib, and since 2 years she's been holding it with all the fingers and places the hand a little posteriorly. Also complains of difficulty in lighting matchstick. Difficulties is such that she was able to identify the matchstick, but she strikes the matchstick clumsily and has been unable to light the matchstick, and hence has stopped lighting the lamp at home since 2 years. Over time, she also noticed difficulty. Over the next month, she noticed difficulty in writing, which was noticed while writing a letter. She says that she was knowing what is the content of the letter. She was able to identify the pen, hold it tight, and place it on the paper. However, while attempting to write, she could write a few words. After that, the handwriting changed, and there are multiple different shapes of the handwriting. Hence, she asked her colleague to write the same letter for her. There has also been repeated rejection of multiple checks due to the change in the signatures. She also complains of difficulty in cooking chapati such that she is able to perform the task. However, she notices that there has been change in the shapes of the chapatis and also has difficulty in manipulating the stick over the dough. There is no cooking error or excess or reduced ingredients that are made in the cooking. The patient also complained of difficulty in drinking from a straw associated with a mild spillage from the angle of the mouth. All this has been since 1 year. There is no history of associated difficulty in chewing, swallowing, dysarthria, nasal regurgitation, or choking during this act. Patient also complains of disturbed sleep, such that she initially required 5 minutes to enter sleep. However, now she requires about 1 to 2 hours to enter sleep. There is no history of nocturnal awakening, excessive daytime sleepiness, or snoring. There is also a history of 11 kgs of weight loss with reduced appetite since 2 years. There is no history of associated early satiety, palpitations, sweating, heat or cold intolerance, visual disturbances, or osmotic symptoms. There is no history of disinhibition, emotional incontinence, personality changes, anger outbursts, obsessions, hallucinations, or food feticism suggestive of a frontal lobe involvement. No history of memory disturbance, difficulty naming objects, recognizing faces, or grammatical mistakes. She denies any calculation errors. There's no history of inappropriate use of objects. No history of motor or sensory weakness or bowel bladder incontinence. There's no history of any involuntary movements, hallucination, or fluctuations of symptoms. There's no history of history suggestive of an alien limb phenomenon. A past history: patient is a known hypertensive since 5 years and has been on regular medications of amlodipine 5 mg OD. There's no previous admissions to the hospital. She consumes a predominant vegetarian diet. Appetite has been reduced. Bowel bladder habits are regular. And sleep, she complains of an increased sleep latency. Family history: there's no family history of similar complaints. There's no history of any neurodegenerative diseases that are running in the family. Coming to summary of the case, we have a 65-year-old lady who presented with progressive difficulty in using various objects since 3 years with a significant history of weight loss. So the neurodeficit, according to the history, looks like a limb apraxia with an orobuccal apraxia. Anatomical localization, I would like to localize it to the left parietal lobe and the frontal lobe. The pathology could be either degenerative or paraneoplastic in origin.
Okay, we'll analyze the symptoms. No.
Yes.
She is previously pre-morbidly. She is not having any other disease. No, ma'am.
No, ma'am.
And you told me about her pre-morbid routine of getting up at 6 a.m. and all those things.
Yes,
so now, how is her pre-morbid routine? Has it changed?
Ma'am, she is because the sleep latency has increased. She says she sleeps for a longer time. Now she gets up at about 8 a.m. in the morning. But preparing breakfast, she is noticing some difficulty as that was described in the complaints, ma'am.
So no major
she's not working. She stopped working now, ma'am.
She's not doing anything in the house.
Yes, ma'am. She's not doing activities, much of the activities, what she used to do before.
Okay. Because we used to tell that what heralds any disease in a senior person. Normally, our routines are established by 18 to 20 years. That's the formative years. So after formative years, our personalities are fixed. And under stress or under severe demand, we might change it. Otherwise, we don't change. So change in the pre-morbid routine, which will be ignored as maybe old age, retired, all those things. But that will be the first symptom. But in this patient, it has changed only now.
Yes,
no, now recently. But
3 years. Initially, nothing was there.
So initial thing is not a change in the routine. Initial thing is difficulty in manipulating her dress.
Yes.
That's what he told. So when you tell manipulating the dress can be difficult due to many situations. No.
Yes, ma'am.
So you said that she has difficulty in unbuttoning, because of which she is using the scissors to cut the knots and so many things. No.
Yes,
so you see having difficulty in mixing food, combing hair. Does she have any other difficulty in other activities? Is it with has she
Yes, ma'am.
So I want to know, because you said that using objects, that is your first complaint. Yes. She has difficulty in using objects, you told, no? And that is manifest as buttoning, unbuttoning, holding on dress, unknotting, like that you told. So these activities are impaired, I agree. But does she have difficulty in mixing food?
No, ma'am. She does not have any difficulty in mixing food or combing hair. There is no history of any motor weakness that she is complaining of.
So it is very important. So your patient has having an action failure or an anatomical failure. So very important to know whether it's an action that has failed or an anatomical structure that has failed. You may not be able to open the jar, you may not be able to unbutton, you may not be able to put on a knot because of difficulty in the small muscles.
Yes,
It can be due to small muscle weakness, which we discussed in the last class, lumbricals, opponents. So that weakness is there, it will be an anatomical failure manifest in all actions which need those muscles. So when somebody is telling, you should ask about all other activities which need that activity. So those activities are normal. Second, is there any twisting movement in the limbs? Is there any sensory impairment?
no.
So even if there is a sensory impairment, patient will have difficulty. So when patient says this, you should elicit and quickly tell, my patient does not have difficulty in holding other objects, difficulty in mixing food, or difficulty in carrying any glass of water. All those things are all right. But she has difficulty in buttoning and unbuttoning. Specific task. So it's a task specific failure of activity. So some tasks there is difficulty, other task it is not difficult. So and there is no twisting observed there, so it's no dystonia. So it's apparently a normal limb in which the person is unable to carry out some actions.
Yes.
So it looks like that apparently. So but you should provide that information.
Yes, ma'am.
So
In
she is
the end,
mixing and
mention it here, ma'am. The end I mentioned.
Oh. So in that case, it is an action failure which is specific for some task.
Yes, ma'am.
So, so task specific syndromes, can you tell me some situation where task is important? In some task, so it is not an anatomical LMN or EMN problem. So it is a task related problem. So task related problems can be two things. Normally there is no dystonia. That's why twisting movement is very important. It's called task specific dystonia, like writer's cramp, speaker's cramp, task specific dystonia of the foot, orthostatic tremors, walking induced foot drop, no? That is Sigawa syndrome and all we tell. So is there, so it's a task specific disorder is the first thing. Some tasks are normally done and some tasks are difficult. Okay, so what are the things which are task specific disorders? One is task specific dystonia, which is the commonest one, seen in many of the inherited neurodegenerative dystonias, which are task specific. So it's a task specific involuntary movement. You will provide information by telling that even though my patient only some tasks are affected, during those tasks there is no twisting movement or no abnormal posturing of the limb. So I feel that it is not a task specific dystonia. Then what is the next task specific? It's a motor schema failure. So you got a motor schema for various activities. So for some activities, the motor schema has failed. So those form a group of disorders called Apraxias. So first you will say that my patient has no LMN or EMN weakness as evidenced by ability to carry out movements which needs that small muscles very well in some other action. So it is a task specific disorder. Task specific disorders may be task specific dystonias, which are very common. I look for that because patient is not having any twisting or turning or abnormal posturing. It is not a task specific dystonia, but it is a probably a motor schema failure. Motor schema for some activities is impaired. So it looks like an apraxia. So that looks like an apraxic limb. So it is happening more in the right side, you said. No? In that case, we will ask three. So she is a right-sided person. Has she shifted in the early phase to left hand?
No,
for her activities?
Of any such,
Usually some of these patients, if they have difficulty in turning the dosha or something like that, those actions are affected, they shift to left-handed. At that time, they won't know. They will think I am little clumsy with my right hand. So I have shifted to my left hand, they will tell. So now your late onset shifting of hand dominance, in case that there is a problem in the right hand activity without any obvious turning or twisting, it's one sign of apraxia, especially when it is a right-handed problem. So you didn't find any dystonia, so is it an apraxia? So that is the question. You called it as useless limb of open hem. No? It is called as useless limb of open hem. Useless limb of open hem, you are not able to demonstrate anything, but the hand is not cooperating. So patients will say, I don't know what is happening. Anyway, I thought I will do with my left hand. So generally they shift to left hand. That you will have to ask a leading question. If it is there, it is very useful. If it is not there, okay, no problem. Then we will say, okay, when the person is doing one task like unbuttoning, what exactly is happening? You see, the first description of apraxia is in a pastor in the church. Okay. It's a Wing Bruin series is describing the first case of apraxia in a priest in the church. So what was happening was he was coming and praying and everything. He has held the cross for several decades, but he was holding the cross as if he has never held it before. That is the statement in Wing Bruin. That priest was holding the cross as if he has never held it before. So he will turn it, tilt it, hold it sideways. He doesn't know something is wrong. But why? How do I make it straight? He doesn't know. So he was holding the cross like that. So was the patient putting the hand in abnormal postures, trying to manipulate the knot in wrong ways, don't know from where to start.
Yes, ma'am.
And carries the limb through an altered trajectory. So those things you should tell. So the trajectory may be changed. It may not be targeted at the knot. It may go around the knot and manipulate in funny way. So it can be easily removed. That is like holding the knot in the cross as if you have never held it before. So patient is trying to unknot as if he has never unknotted before. She has never unknotted before. So much confused, thoroughly confused. That is an apraxia. So that's an apraxia. You don't demonstrate anything. So what are all the apraxias which manifest in the hand? Can you tell me, ma? The hand.
One is one can be alien limb syndrome that can be there.
Okay. Alien hand syndrome is an automatic hand. It's a strange hand which acts as if it is getting orders from its own brain. It's a different brain. That is why there are people who describe the DNA. Who are they? Watson and Crick. No, they wrote something on cognition. So they wrote that soul is in the cingulum. Yes, they found that patients who had alien hand syndrome in postmortem, they described on alien hand syndrome. They did postmortem and they found a lesion in the cingulum. So they said soul is in the cingulum. So alien hand means it acts. When I am writing, it will be running here, there, as if it is doing some other activity and some other person is giving order to that hand. It does not obey the general flow of the brain. It takes orders from another soul. So a double soul, it is something like a double soul is there and that hand is taking order from another soul. So Watson and Crick, they wrote a book called A Scientific Search for the Soul. And in that book, they have written that cingulum is the seat of the soul. Because singular lesions, the hand is independent, does not obey the rest of the body. So it can be an automatically wandering hand, or it may be an intramanual conflict when it is fighting with the other limb. Like that, you have got frontal alien hand when it's an extended grasp, parietal alien hand, wandering hand, or it can be an intramanual conflict. That is not happening. So patient is in the limb, you can have ideational apraxia. So now we think that it is not an alien hand, it's not a wandering hand, it is not a fighting hand. So alien hand is a wandering hand or a fighting hand. Both is not happening. He is only unable to do some activities. So it is an apraxic hand apparently because most of the activities are all right. It's an apraxic hand. So in the apraxic hand, you can have ideational apraxia.
Ideomotor.
You can have ideomotor apraxia. You can have limb kinetic apraxia. So it is coming under what kind of apraxia? Next. Is it an ideational apraxia? Would you like to answer, ma'am? Do you think it's so now we think it's an apraxia? Probably it is not alien hand, it is not dystonia, it is not LMN, it is not Yemen. So it may be an apraxia. So is it ideational apraxia?
Unlikely, ma'am, because here only motor schema is being altered, and the entire schema, the in her mind, the idea is very clear how she has to perform the activity, and the sequence in the mind it is very clear. Only when it is being executed, there is a problem. So it's
So
unlikely
what
to.
will be the manifestation in unbuttoning if your patient is having ideational apraxia or making chapati or using the pen? Let us imagine it is an ideational apraxia in the use of an object. You said the first symptom is difficulty in use of objects, no? So if it is an ideational apraxia, what will be the symptom of the patient or the symptom of the bystander?
Patient may not be able to know why that object is being used.
Hmm.
That,
So supposing patient has to write.
yes, ma'am.
So the patient will be able to identify the pen.
Yes, ma'am.
Like unknotting, patient will be able to identify the knot. Patient will be able to say, this is the knot in my skirt. Okay, you start unknotting your skirt and you change your skirt. You tell the person. Then the person will start looking for objects elsewhere. So patient identifies the object. Patient knows what he has to do in the mind, as he said, clearly patient knows what, all apraxias, patient know what they have to do. So all that is another feature of apraxia. They know what they have to do. They don't know how to do it. So on ideational apraxia, person knows he has to write or he has to write unknot as much chapati, patient knows. But and you tell where is the knot, patient will say here is the knot. Where is the pen? Here is the pen. Where is the chapati dough? Here is the dough. Okay. So patient knows what he has to do in his mind. Patient knows what are all the objects which are to be handled for the objects, all the objects like the dough or the knot or the pen, everything they know. Okay. Now you know the pen is there. You have identified the pen and you know that you have to write. Sir, you start writing your name and address. You tell the person. Then the person will take a brush or a book and start writing. So even though the idea is very clear that you have to write your address, even though the person knows that the object, that is a pen, is there and he has identified the pen, there is a delinking of the concept. So that's a posterior apraxia, parietal apraxia. So the patient will use a wrong object, even though he has identified the object and he knows in his mind what he has to do. When multiple objects are kept and told to choose the object, the patient will choose the wrong object. You will be surprised. Sir, did you not identify your pen? Why are you? I know, but this is how I write, they will say. So it's a conceptual apraxia. So failure of the concept. So even though they have the idea, even though they know the object, failure of execution of the concept. So patient identifies the target very well. You tell what is, I have to write my address. Okay, start writing. He will take the duster or take some key or something you have kept there and start writing. That is ideational apraxia. Even though everything is very clear, when it comes to action semantics, it's an action semantic failure. Action memory failure. Action memory alone is failed. Object memory is there. What to do is there. But action semantic failure, that is ideational apraxia. So this is not ideational apraxia. When she wants to unknot her skirt, she is not trying to unknot something else. She is going to the correct only. When she has to write, she is taking the pen only. When she has to make chapati, she is going to the chapati only. So it is not ideational apraxia. The object is semantically not chosen wrongly. So it's a motor semantics is all right. She is not using a wrong thing to make chapati.
Yes, ma'am.
So it is not ideation. If it is ideomotor apraxia, when the person, like the priest, he did not know how to hold the cross. Patient will not know how to open, which place he has to reach, and so they will be making funny movements. You will think they are psychiatric or what? They will go around the knot to look here, they are pulled from the wrong side and do all those things. And you said that the person has difficulty in holding the pen. I had a video, I think I could not show, but I wanted to show in the last session. The patient is a teacher. She was holding the pen up, down like that. going on carrying, wondering what to do. So that is, target is chosen correctly. But what are all the types of movement? You see, if you have to hold the pen like that, you have to lift it, you have to open it, put it on the paper in the proper way and start writing. You told that she was holding the pen like a dagger. So she did not know how to hold the pen, even though the muscles were all right. You hold the pen like a dagger when your long flexors are normal, but other muscles are weak. But that is not there because she is able to mix her food. So that part is not there. So she was holding the pen like a dagger, and she was bizarre and making big letter, small letter. So that means she did not know the sequencing of the motor activity. So smooth sequencing of the motor activity is, you have got a Lippmann's model for apraxia. So you give a command to the patient. Sir, start writing your address. Okay. The command is registered in the Wernicke's area.
Okay.
And its meaning is interpreted, it is registered in the auditory cortex, Heschel's gyrus. From there, okay, I have been asked to write. That command interpretation is taking place in the language area. Command is heard through the Heschel's gyrus. It is interpreted in the Wernicke's area. Okay, you have been told to write your address. So that, okay, I have to write my address. This involves this many letters. So how do I put it on paper? So this Wernicke's area, through the arcuate fasciculus, give the order to the supplementary motor area. Some of the information also goes to the basal ganglia, and that will prepare the schema. So this is what is to be written, my name, my address. So I have to hold my pen like this and lift it down, big what loop or whatever I have to do, and then make the letters correctly. So that is the motor schema. So the motor schema is like the house plan. Before we construct a house, we make a plan. That is the schema. So the motor schema is prepared by the supplementary motor area, assisted by the basal ganglia and cerebellum. Then that schema is brought to the motor cortex. That is the precentral area. Supplementary motor area is in the medial side, area 6. It is a premotor. Area 6 is in front of area 4, and it spills over to the medial side, that is area 6. That prepares the schema in consultation with basal ganglia and cerebellum. And that schema is brought to the precentral area, that is area 4, for execution. And area 4 through the corticospinal tract sends it to the dominant hand. And if it is for the non-dominant, through the corpus callosum, it goes to the right side. From the right side, the action is transmitted for the left hand. So it is language linked. Praxis is language linked because it is really linked to command. So command is processed by the auditory cortex. The auditory cortex conveys the phonological information to the Wernicke's area. Wernicke's area makes meaning out of the command, and that command is converted into a motor schema by the supplementary motor area in consultation with basal ganglia and cerebellum. And this prepared motor plan or the motor engram, we call it as a motor engram. This motor engram is given to the motor area, that is area 4, and the area 4 will send it to the right hand. Okay, you have been asked to write, you write. So you are telling, okay, sir, you lift your cup with the left hand. Then how does this happen? Through the anterior corpus callosum, it goes to the right side, right motor cortex straight away, and it comes to the left side. So this is the second part. First part is interpretation, that is hearing and meaning out. That part is conceptual failure, ideational apraxia. So that will be the link in the there. So supposing it is a execution, formulation of the motor schema, then it is in the anterior pathway of the Lippmann's circuit. It is called Lippmann's circuit. Forming the motor schema. That is what happens in ideomotor apraxia. The motor schema is not formed properly. How do I hold my pen to write my name, then my door number, then my state, district, or whatever it is? So the motor schema is erratic. So it can be split. So you split the command. Okay, sir, you have to take your 2 fingers and put it on the pen. So, okay, put it on the pen. Now you lift it up, lift, then put it like that. So if you split the command, they may be able to do. Or you tell them, forget about the moment, you look at the pen and do. So concentrating on the target of action will improve the action rather than the action, because it's an action failure. It's an action failure. So these are training methods. You have to tell them when you have to write. If you are thinking how I am going to hold the pen, you will never write. Instead, you just take the pen and write reflexly. So that is why we call it as voluntary reflex dissociation. So when the patient is told to make a chapati, or told to write the address, or told to unknot, it will be more difficult. That is why we say context dependent. In the laboratory or in the set examination table, in the doctor's room, they are very, very clumsy. But at home, the patient at home, she was not this much bad. Occasionally, she was dressing. Occasionally, she was making chapati. Because it is context dependent. Second important factor. So schema failure, so sequencing is defective, context dependent. So in the examination setting, they are more clumsy because they are concentrating on the action. Whereas reflex, you are not concentrating on the action. Supposing you want to drink a cup of coffee, mainly when you are rushing to your hospital, coffee is kept on the table by your mother or sister or somebody. We are not going to think, how am I going to lift the coffee, take it to the mouth and drink. But in the setting in the doctor's room, you lift the coffee and drink. When we tell, the person will think, oh, how am I going to lift it? But when you are rushing to the hospital, you just take it and drink. You are not thinking about the action. Only you are looking at the coffee and put it in your mouth. That is called voluntary reflex dissociation. Voluntarily, when a command is given and told to carry out a command, that is difficult because you are concentrating on the movement. But when you are rushing and take a cup of coffee, drink and go, you are only looking at the coffee. That's a target. You are not concentrating on the movement. So that is the second component. So all other factors should be normal, and voluntary reflex dissociation and context dependent and fluctuation, because it is context dependent, naturally it will fluctuate. So that is ideomotor apraxia. So apparently our patient seems to have ideomotor apraxia. She is holding the dough making wood in a wrong way. She is holding the pen posteriorly and like a dagger, you said. Next, is it a limb kinetic apraxia? Limb kinetic apraxia is again very much like a motor failure, if you are not knowing, because it will look like a bradykinesia. But you call it as apraxia because sequencing of the movement is more affected and not just slowness and bradykinesia. So limb kinetic apraxia is wrong timing, wrong targeting, wrong planning, but it will not be like sequencing. So sequencing defect is ideomotor apraxia. So what your patient is showing is not limb kinetic. Limb kinetic apraxia will be slow limb. It will overshoot or undershoot the activity. It will be slightly clumsy. It differs from bradykinesia in that action itself is not affected in bradykinesia. It is slow and progressive smallness, whereas clumsiness is added into limb kinetic apraxia. It's a dull limb. You tell the person to bring, slowly he will bring, but he will reach the level. You don't know why. He is not having paralysis, he is not rigid. Why is he bringing it slowly? So it is alteration in the speed, overshooting, undershooting, holding clumsily. That is limb kinetic apraxia. So apparently, your patient has a normal LMN, which you have judged normal UMN apparently, and there is some activities are normal, some activities are affected, and the affected activities are not task specific dystonia. The objects are used properly, but the sequencing of the movement is made clumsy and patient is confused. So it is an ideomotor apraxia. Apparently, it looks like an ideomotor apraxia. Second, you told that when the person is putting the paste in the brush, You have to describe how is the patient holding the paste. How is the patient holding the brush? Is he taking somebody else's brush? Or is he using the paste to brush? No, instead of using the brush. So all those things you will have to tell. So instead of using the brush, he is trying to take the paste. Then it is ideational.
Okay.
And if he is putting in the posterior part of the brush, that is what you told. Is it because patient is really trying to put it in the proper place, but he is clumsy, doesn't know how to put it wrong? Then it is an ideomotor apraxia. So person with ideomotor apraxia knows he has to put it properly only, but he will go down, round, and he will put it like that with clumsiness. So it goes posteriorly. That is an ideomotor apraxia. But if he is not clumsy or anything, but he just puts it posteriorly, that is a judgment failure. Just putting posteriorly is a judgment failure. It goes to frontal lobe. Poor judgment. Where am I? Supposing you have got a whole page to write, and you think that the class is going to be for half an hour or 1 hour, whatever it is, and you want to write some 10 points, and you start from the lower. It is a judgment failure. You want to use less space only. Why you want to waste space? So a person with proper judgment who knows that there is a half an hour session will start from the top. But if he starts from below, it is judgment failure. But he starts correctly, he knows correctly, but is unable to target that location because of the motor schema failure, sequencing defect. So even though patient wants to try, but he goes around, somehow he makes the paste fall on the brush and it falls posteriorly. That is an ideomotor apraxia. So it can be more than one phenomena in a patient. So you have to ask, you have to elaborate. So cognition, most important is the eyewitness description. Very important. Or you will have to demonstrate. In that case, you have to take a lot of time. So you see whether he is straight away he is putting posteriorly. That is a judgment failure. But he goes clumsy down and manages to put it and it falls posteriorly. It's in the absence of finger-nose incoordination, in the absence of dystonia, in the absence of myoclonus, he tries his best but puts it posteriorly. That is ideomotor apraxia. So it may be frontal lobe or it may be ideomotor apraxia. Both are possible. Next thing you told that he has a writing problem.
Yes.
Then you told that he is holding the pen in a wrong way, even though his small muscles are apparently all right. You need your opponents and you need your lumbricals to hold the pen. If they are all right for mixing food and he holds the pen like a dragger, it is like an ideomotor apraxia only. It's an ideomotor apraxia. Then signature has changed, you told, no? What exact change has taken place in the signature?
They've said that the patient is not obeying the symmetry. Like initially, let's say the letters are compact, it has become wider one, ma'am. And the letters also, there is no, initially if it was all narrow, the letter size also has been variable, ma'am. It has changed.
So one, supposing in this person is having some extrapyramidal syndrome, like a Parkinsonian, that is very much possible. So in that case, what will happen to the letter?
It will become micrography. A patient will write very small.
So it will become progressively small.
Smaller.
Progressively small. Supposing this person has got a cerebellar disease, what will happen?
There will be interspersed. It won't be.
It will become macro. It will become big. So if the person has got extrapyramidal disorder, progressive smallness. Cerebellar disorder, progressive bigness. So what condition you get big and small? What all conditions? Suppose you have got a metamorphopsia. So somebody who is seeing the environment as big and small. So supposing somebody is seeing the environment small, micropsia, then you will write big, but it will not be progressive smallness. It will be uniform big. Uniform. It is unlike a cerebellar progressive large. Here it is uniform large. The person who says, I am seeing everybody like Lilliputs. Okay. Yeah, we want to know whether it is a psychogenic or organic, you tell the person to write, you will write big. Because for him, that is looking small. So that big letter is very small for him. That is his self-monitoring of what we write. All of us have got a particular letter size, which we learn from childhood. That we do not change. So when he writes big only, he says his usual size. So he will write big. So micropsia patient will have macrographia. Then macropsia patient will have micrographia. Irregular big and small can happen with metamorphopsia. So supposing it will have a pattern, but 3 letters are small, 4 letters are big like that. So patterned metamorphopsia. Then you can see that it may be a metamorphopsia. Or letter construction can become erratic. So they do not know to write one letter, how the letters are constructed. So it can be a constructional apraxia. So in constructional apraxia, they will put one long, one big written, serrated. So that is a constructional apraxia. So the handwriting can be erratic due to many things. So it can be, or if it is due to chorea, you will find dots. Every time the chorea comes, there is a dot because they hold the pen like that, wait for the chorea to go and then start writing. So that will produce dots. So irregular mixing of, supposing you have got a writer's cramp. What happens when you start writing, your handwriting is better. But when the twisting comes, the letter becomes very much altered. That also happens in writer's cramp also. So if the person, so you have to describe many things. If the letter got changed, signature got changed, is there a content error? Supposing it's a language problem, the content will be altered. So when the person is writing, has he changed the way he writes the name? So one letter is substituted, paraphasic writing, maybe Wernicke's aphasia. We don't know, no? So when you describe that the patient's check got rejected, so many things, handwriting change. So did it become progressively small? Did it become progressively big? Was it a mixture of big and small? Was there a letter construction defect? Was there a spelling defect? Was there a poor meaning happening? Then it becomes part of a language disorder. Or was the patient holding the pen in a dystonic posture? When he started, it was all right, but went on writing erratic, it is writer's cramp. No? Progressively, the arm twist, the limb will go up, a tremor will start. All those things are happening or not? Nothing was happening, but my patient was holding the pen wrongly, like a dagger, and he did not know how to open and how to close, and he tried to write with the opposite side, and he wrote in a clumsy manner, holding in the not in the usual way of holding. Then it becomes apraxia. So you should, because the handwriting can be altered in everything. So when you are presenting a history to your examiner, you are making the examiner understand that you know all this. Okay. You know all these things. Yes. So that is the history of the presenting feature. So handwriting change, check got rejected. So whether there is a content problem in the written material, or what is shape, size, construction, or is it the limb that produced the problem? It is not in the letter construction or anything, but the limb went bizarre. He was holding wrongly. So this happened. Then it can be a apraxic hand, where the patient is holding the pen in a wrong way and writing it like that. So if you get all those information, we will make a conclusion. Exactly this is the problem. This happens. So because already there is an apraxia, this could be very much an apraxia, but you have to describe that it is not something else. Because a person with one apraxia, everything else need not be apraxia. They can have many other things. So you have to explain like that, then we will know, because these persons can have extrapyramidal involvement, very much common. So it may be a progressive smallness, or they can have tremors, they can have sensory impairment. So all those things are there or not. So if you ask and explain, if it is negative, you will tell it is negative. So I think this person was using the pen wrongly. Was it so?
Pen was wrong, man. The way they held it. Everything was wrong.
So the proper way of holding the pen was not there.
Not
Was there any twisting? Because
No,
that
no,
happens even in writer's cramp.
no twisting, no dystonic movements. No
So
any-
that's very important. Because the pen is held wrongly even in writer's cramp. They hold like this and all. No? So even writer's cramp, it happens. And the proximal part will be tilted, tremors will come. So those things were all not there. Still, she was holding the pen clumsily and did not know how to move about with the subsequent letters. Then it may be an apraxia. Okay, then you told that patient had difficulty in sipping from a cup. No?
Yes,
Was so you explain that little more. Sipping from the cup, what all muscles are involved?
One is the opening of the jaw that will recur. The first would be the opening of the jaw. That will require the pterygoids action.
Yes.
Then
Which pterygoids
lateral
open?
pterygoid is required for opening
Yes.
of the jaw.
Both lateral pterygoids together open.
Then she needs to use the lip muscles to.
So orbicularis oris.
Orbicularis oris is
So
required.
main muscle involved in sipping is orbicularis oris. So does he have any weakness of orbicularis oris? At rest is there, drooling from the sides. Then that we call it as flat lips and prominent upper lip, pouting. All those things are there or not that indicate that orbicularis oris is suffering a element weakness. So it is not there. It's not rolling from the side. She's not bilateral facial palsy. So M&D. So they can have weakness. So she's not rolling from the side. Okay. Then when she's able to open the jaw. Is it so?
Yes, ma'am. She's able to open the jaw.
Okay. When she tries to sip, what does she do?
When she tries to sip, she is able to sip for some time. After that, she stops, ma'am. There is some spillage that happens while having the when she's trying to sip. After that,
can she speak the labials well?
Yes, ma'am. Labials are.
Pa, papadam. Those letters are labials, no?
Yes,
PB. So you should highlight that in this patient.
Okay.
So my patient is not having drooling from the sides. She is able to hold the food in the mouth and she has no difficulty in communicating the labials, but she has difficulty in sipping from the straw. And that means probably it's again a motor schema failure in the oral muscles. Midline apraxia. So I got ideational, ideomotor, limb kinetic, which are appendicular apraxias, and gait apraxia, buccal pharyngeal apraxia, apraxia for swallowing, apraxias for speech. They are all midline apraxia.
Okay.
So apparently she had an ideomotor apraxia, and now she is getting a buccopharyngeal apraxia. No? Then does he have any? Now you said that some problem with the sari that forced her to shift to house coat. No? So what was the problem with the sari, ma'am?
When she was trying to, initially she was able to wear the sari properly, the schema, there was no any weakness. After that, she had some clumsiness in the movements. Initially, the pleating was very regular. After that, she had difficulty in pleating properly. And also, she had difficulty in correctly making the pleats and tugging it properly, ma'am. So when she had such difficulties, she used to call her daughter very frequently. So initially, with the help of the daughter, she was able to do it. Then the frequency increased over a period of 2 years. Because of this worsening, she stopped wearing the sari and she switched over to gown.
So what you have to ask, what are all the things, problems which can happen in dressing? It can be element human, that is not there. She is able to hold it. So power is not failed. Power has not failed. So she can hold it. So element human part is not affected as evidenced by normal power. With reference to dressing, you can know many things. You see, one thing, you may try to wear the sari through the head. You may think that sari is a blouse, no? So is she trying to make use of the sari in the wrong way? Or they may wear the sari inside and undergarments outside. Or the inner part outside and the outer part inside. or the top down and the down down. You have put some pleats, something in the, to keep it standing. We put no, so attach something to the lower part of the sari. That she is putting up. So is it there? Then is she, so you will have to ask all those things. And then is it in the pleating? So inside out is a visuospatial error. Upside down is a visuospatial error. And trying to you use the pant as a shirt or shirt as a pant is complete failure of the, it's an ideational error. No? Then pleating error is a sequencing error. Sometimes, what other things you can get with reference to dressing in the absence of weakness? So this looks like a probably a dressing apraxia, because you said that's a pleating, it's a sequencing error. Pleating problem is affected, so it looks like a sequencing error. But what other things you know with dressing can happen? Once I told they may wear the sari on the head. We have seen such patients. Patients trying to put the pant through the head or the shirt through the leg. No? So that is not happening. The inner garment outside, that is not happening. They may be obsessed with one dress. That's an obsession. It's a frontal lobe. They never refuse to change the dress. The same dress every day bathing and wearing the same dress. That's an obsession. It's a frontal lobe syndrome. Then lack of personal hygiene. They may not wash it at all and use the same dirty dress. That is lack of personal hygiene. It is again a frontal lobe syndrome. Or they may put one shirt over the other. It's an environmental dependency. You are already wearing a shirt and you see another shirt, you put it on top of what you are wearing. So that is again a stereotypy, motor stereotypy or environmental dependency. So with the reference to dressing, it can be obsession with one dress, using unclean dress from frontal lobe, or using one dress over the another, that is again frontal lobe, or sequencing error, which is parietal lobe, or they may put above down or below up, that is again a dressing apraxia, or they can have visuospatial error, inside out, outside in. So these are the various things in dressing you can get. In your patient, it is, she is using the correct sari only, and she is using the correct method only. She is not putting inside out, so visuospatial error is not there, but she has a pleating error. So it's a sequence disorder. It looks like a dressing apraxia. But dressing apraxia can happen with both dominant and non-dominant.
Okay.
So this is called as a pseudo apraxia. It is not language linked. So it is both happening in right parietal and left parietal disease. It can happen. So it is a called as a pseudo apraxia. So that looks like a dressing apraxia only. So now we are having so many apraxias. Initial apraxia looked like an ideomotor apraxia of the right hand. Now we have a dressing apraxia, which can be right or left, either side it can happen. And she is now, so at this point, what other symptoms you will ask me?
History of, because there is, when we have the apraxia and this.
Would you like to define apraxia, ma?
Definition is inability to perform a learned motor task in the absence of motor weakness.
Motor, sensory or cerebellar defect on command. So inability to carry out a learned motor act in the absence of motor, sensory or cerebellar defect on command. So that is a definition of apraxia. So now we are having apraxia, which is either dominant or bihemispheric. We don't know, because dressing can be happening in both hemispheres. So at this point, what more history you will ask?
Because it may be either dominant or non-dominant. To localize it to the hemisphere, we'll ask for history of any difficulty in the arithmetic calculation problem if the patient is having. Any difficulty in identifying the right and left side if this patient is having. That is one more.
Is it all there? Is it affected or normal?
On examination, it was affected. History-wise, they did not come forth with that history.
In other words, you see the apraxias are predominantly parietal lobe. And its connections. There is Wernicke's area through the arcuate fasciculus, through the parietal lobe, it goes to the motor cortex. So that is the connecting part. Undressing apraxia is non-dominant parietal. So you look for other parietal lobe features like visuospatial disorientation. Instead of going to the toilet, is the patient going to the kitchen and saying, I am thinking this is toilet, I am sorry. So you will now go to other elaborate features of parietal lobe. Is the person having problem, confusion in going out and buying a cover of milk? Instead of turning to the right in the familiar environment, patient is going to the left. Is the person having a parietal wandering? Parietal wandering means they have the aim of destination. They want to go to the milk shop and get a cover of milk. In the house, they will tell, I am going to get a cover of milk. But they come out, they don't know which way, right or left. Geographical orientation is poor. They ask 1,000 people, where is the milk shop? Then they will tell, here's the milk shop. Go there, pay the change, and for get back the change, for come back again confused. So that is a geographical disorientation. So is there a visuospatial disorientation inside the house, or is there a geographical disorientation? Then is the person misplacing object? Most of the houses have got place where you give puja material, place where you give cooking material, place where you give study material, or you keeping it in wrong places and keep on searching. A person who is doing it properly only along with other family member is suddenly putting in wrong places. All this point to visuospatial disorientation. Then you can ask for any sensory seizures or any sensory cortical sensory deficit or any neglect. Is there any hemispatial neglect? Is there any hemianopia? So all this you will quickly tell. My patient has all these presenting features, because of which I thought whether any problem with other parieto-occipital region. So patient, if there is a neglect, how will the person tell? I think this person is very funny. When he is going out of the door, he seems to skew himself through one side, even though the whole space is there for him to go. So a person with neglect won't know that whole space is there. So for him, only one half is there. So he will skew himself through that half, thinking that there is only a less space. So such a manifestation. So even the whole room is there, you are sitting like that. What happens, sir? So this much space only is there. Or it may be egocentric. Then you put your powder on one side, comb your face on one side, or shave on one side. No? So it may be egocentric or ergocentric neglect. Egocentric neglect will present as lack of shaving or putting powder or whatever on one side only and not putting on the other side, or skewing through narrow spaces even though the whole space is there, and unable to identify the door or window through which they got in. And when they sit in the chair or in the toilet commode, they will sit in one edge. Relatives will tell, even though the commode has to sit properly, he goes and sits on one side. When I tell him to sit in the chair, he sits on the edge and tries to fall. These are all visuospatial judgment and error in spatial orientation. Then you can have finger identification, cortical sensory loss. You see, feeling the surfaces, weight, texture, all those things properly, or he has lost those skills. And as you said, finger identification can be told. So you will ask for other parietal features, whether they are affected or not. Then other parts of the neuraxis. So one, we are having apraxia now. Okay. In addition, is there other part of the same hemisphere is affected or not? Other part of the neuraxis is affected or not? Other hemispheric functions are affected or not? Or other systems are affected or not? That is how you will expand. No? So now you have apraxia. Next symptom you told sleep.
Yes,
so how do you categorize sleep disorders now? It is categorized as disorders of initiation and maintenance of sleep. Then, so next is disorder of sleep-wake cycle. Then you have got disorders of excessive somnolence, and then parasomnias. So when there is a sleep complaint, is there any disorder in initiating and maintaining sleep? In your patient, there is an initiation failure, maintenance is all right. So he sleeps till 6 o'clock and his sleep hours have not changed, but the sleep onset there is a problem. So this is a problem in sleep initiation, maintenance is okay. So it's called DIMS, disorder of initiation and maintenance of sleep is called DIMS. So initiation is all right, defective, maintenance is okay. So it's not fitting into DIMS, it is only disorder of initiation. DUS means disorder of excessive somnolence. That is DUS. So that those people will be always sleeping. So those who are disturbed sleep at night, in the classroom they will sleep. Or they may have narcolepsy, sleep attacks. So disorders of excessive sleepiness happens due to many causes. Paroxysmal nocturnal dyspnea, frequent urination at night, nocturnal asthma, cardiac failure. So those people are not sleeping at night, so snoring, and they may sleep at the day. So just to characterize the sleep as DIMS, DUS, sleep-wake cycle abnormality. Sleep-wake cycle abnormality means normally we have a 8 hours of sleep in REM, 8 hours of sleep in NREM, and 8 hours of wakefulness early stage. Later, it narrows in a particular fashion so that NREM dominates, REM shrinks to 1/5 of the sleep cycle. So it can be sleep architecture change, where the REM and NREM is getting contaminated, so you will have so many parasomnias. Or it can be sleep-wake cycle abnormality, means normally we sleep for 6 to 8 hours at night and sleep wake rest of the time. So it may shift. Patient may be sleeping for major part and wake for, that is within 24 hours. So sleep-wake cycle abnormality can be within 24 hours or non-24 hours. Non-24 hours is the, you see that Klein-Levin syndromes, hypothalamic syndromes. So Kumbhakarnan, he will sleep for 3 months and wake up for 6 months. That's a non-24 hours. So sleep-wake cycle anomaly can be 24 hours. That happens in people who do night shifts. So you've done a night shift for 2 days and then you are shifting to day shift. Then there will be a 24-hour sleep-wake cycle abnormality due to erratic work environment. But hypothalamic syndromes, they become prolonged non-24 hours sleep-wake cycle abnormality. So Klein-Levin syndrome and all. So that is the third group. Fourth group is parasomnia. Parasomnia will be RBD. At night he is shouting, howling, hitting, or restless legs, somnambulism, bruxism. So all those parasomnias are there or not. So in your patient, apparently there is no parasomnia, there is no excessive somnolence, there is no maintenance problem, there is no PND, there is no nocturnal GRD, reflex, nothing, but he has just difficulty in falling asleep. But the person is not getting up early also. So falling asleep alone is difficult means it is generally considered as a manifestation of anxiety. So a person who is slightly anxious finds it difficult to sleep, and depressed persons wake up early. They fall asleep normally. So you should say that my patient has a sleep problem, but it is not fitting into DIMS because he has difficulty in falling asleep, but is maintaining sleep well. And he has no DUS because there is no excessive somnolence. There is no sleep-wake time change. There is no parasomnia. So it is just a problem in initiation of sleep. So he is worried, some insight is there, something is happening to me. I am needing help for dressing, I am needing help for writing. So something is wrong with me. So it indicates anxiety. So it's not fitting into the classical pathological sleep disorders. It's only initiation of sleep. So it looks like an anxiety. No? Then what else? Severe weight loss. No? So this much 10, 11 kg weight loss in 3 years. Huh?
2 years, ma'am.
2 years.
2 years.
So we say that it is very pathological if the person loses more than 10% of body weight in 6 months. No?
Yes, ma'am.
So she lost how many percentage? Absolute weight you told.
Yes, ma'am.
So it is.
It
I think 11 kg is definitely very significant. No.
Yes, ma'am.
So as you said, you should think of in a senior person any occult malignancy as very much possible. What other conditions you get this much weight loss? Ma? So it can be malignancy.
Well, it can be endocrine
Diabetes.
like
Yes.
thyroid and diabetes commonly, ma'am.
Yes. Diabetes mellitus, thyrotoxicosis, malabsorption syndromes. No. Then you can have mitochondrial hyperthyroidism. It's called left syndrome. It's a mitochondrial disease where most of the mitochondrial disease it is reduced BMR. Whereas there is a mitochondrial non-thyroidal hypermetabolic state. It is called mitochondrial hypermetabolism. Mitochondria produces more oxidation. Normally it is less oxygen transport. There are some situations where there is more oxygenation. That is left syndrome is called. So it may be diabetes, it may be malignancy, it may be malabsorption, it may be hyperthyroidism, or in neurodegenerative disorders also there is weight loss. FTD, AD, no, they do lose weight because of altered appetite and food habits. And then there can be an apraxia. You said that she has difficulty in
eating.
So they can have apraxia of eating. Because of that, patient can lose weight. Whether so all this will keep. Would you like to tell me other eating patterns you see in patients? Because there is so much of weight loss, no? So what are the eating pattern abnormality you will see? You will ask for in a patient who claims difficulty in sipping, weight loss. So what other patterns you expect in a person with a progressive disease? And that will help you to make a complete diagnosis, no? Some patients may eat from children. No, 65-year-old lady, normally our grandparents in the village setting, the delicacy food will be kept for the grandchildren. They will share it with them and not eat at all. But this person is taking from the grandchild's plate, night when everybody is sleeping, stealthily going to the kitchen, stealing and eating. That is called food faddism. Especially it is for sweet. But I have seen food faddism for vitamin C, biscuits, and one person non-veg. So that family was terribly shattered. Every time he wants so much of non-veg, they cannot give only. So that is food fat. So my patient has got difficulty in sipping. She has lost weight. Apparently, whether there is a manipulation problem or severe refusal of food that you are not knowing. So we will ask no food fat. No. Second, you may have loss of social inhibition. So when you are going to a social place or sitting in the table and eating, you take from other person's plate and eat. No, that is loss of civil restraint. It is called loss of civil restraint. That's a frontal lobe involvement. So apart from, as I told, when there is an apraxia, you look for the same hemisphere, neighborhood hemispheres, subcortical area, systemic involvement. Like that, you will go. So the person does not eat from other people's plate. Or the person forgets he has eaten. So complains to the neighbors. They are all eating, they are not giving me food. So you would have just finished the breakfast and you are taking it little late. They will come and complain to the visitors. You see how he is eating dosha, he is not giving me. No? That is forgetting. Forgetting that he has eaten, so they keep on eating. Frequent eating and demanding food. Forgetting that they have eaten. Then stimulus bound eating is there. So they know they have eaten, but somebody is eating, then okay, I know I have eaten because you are eating, give me also. No, that we call it a stimulus bound eating. No? Then sometimes they have no judgment failure. So a person who eats 2 idli, he may eat 10 idli. So they become very fat also. So So that also happens. So it can be frequent eating, it can be buccopharyngeal apraxia, it can be food faddism, lack of civil restraint, eating from neighbors, no? Or they may eat excessively, not knowing satiety, or they may have clumsy eating. Supposing there is a frontal lobe, there can be an attentional failure. Then what they will do is, they will eat only the rice. They won't know that poriel and all those things are kept on the side. Then you tell them, you see that poriel is there. Okay. So after they finish the rice, they go to the poriel. No, if you don't point, they may not eat it. So eating only what is right in front of them is an attentional defect.
Okay.
Or they may have neglect. They may not eat from one half. So eating problems, when there is an eating problem, you elaborate on all the eating patterns and you tell the examiner so that you know all these things happen in patients, and that will help you to make a diagnosis. If you don't ask, they may not tell. You're their own parents now. So my mother is eating from my grandchild's plate. How they will tell? They will feel very bad. So they will not tell us. So you'll have to ask. Mostly these kind of problems, you have to ask them leading questions. You have to ask, did you ever eat from the grandchild's plate? Or when to wedding house you felt embarrassed? They won't tell. Because they don't want to project their family member having become very odd. No? So they may not project it. So those questions you will have to ask. And when there is an eating problem, like a sleeping problem, you tell all the sleeping patterns and say it's not there. When there's an eating problem, you tell all the eating problems and say it's all not there. That knows that you have gone across the hemispheres and look for any other part of the hemisphere involved in the similar context. Because each function is so much, you cannot ask everything. But whatever is there in your patient, that you travel across the rest of the hemisphere and tries to elicit everything. So all those things are not there. Some apraxia is there. So is apraxia causing the eating problem and weight loss? That does happen. Is it because of that? Sometimes they refuse to eat. They'll spit. Especially the frontal lobe patient, they behave like children. Then like in children, no, you tell the ambili mama and tell them to eat. So you have to distract them. And swallowing is all right, everything is all right. But they simply are stubborn. They refuse to eat. That also happens. Then also they lose weight. Then the family won't know what technique to use. How many days we'll take to the hospital and give IV fluid? No. The technique is to distract, just like a child only. You distract and show something else and throw food into the mouth. It is like that. So all those things are there or not? No, nothing. So it may be having a systemic cause, we have to seriously look, or it may be part of any other malignancy, all those things which with significant weight loss is there, you'll have to look for a cause for that. So next, what else? Only that much?
That much.
So as for so far from the history, we have only biparietal involvement.
Yes,
No? She is a female. So what are all the possibilities? So biparietal involvement, you said that she is a predominantly vegetarian. So would you like to consider vegetarianism as the cause for this person's dementia? What vegetarianism produces dementia? Vegetarians are protected from dementia. Generally, vegetarians do not become demented. I feel so. But still, they vitamin B12 deficiency.
B12 deficiency.
No. So what is the manifestation of B12 dementia? So you have said predominantly vegetarian diet. So if she is a vegetarian, it's a reversible dementia. Always look for a dementia which is reversible. So because you have specifically mentioned vegetarian, so would you like to consider, is this a vegetarian dementia? It's a frontal lobe. So it's not a parietal lobe dementia. So you should say that as per the current literature, B12 deficiency dementia is a frontal lobe. So it will be behavioral problem. They have delusions. They have other behavioral manifestations of a frontal lobe. So my patient seems to have parietal lobe involvement, apparently from the history. So I'm not considering. After examination, you may get more, but it looks like a frontal lobe involvement, parietal lobe involvement. So it's less likely to be due to vitamin B12 deficiency. So B12, even though patient is vegetarian, that's not the culprit. Appetite is reduced. Appetite is reduced or food intake is reduced. Appetite, that's what you should do. Because appetite reduced means patient knows, I'm not feeling like eating. I feel satiety. That is if the person says. So here you should be using food intake has reduced. Why it has reduced, you don't know. Is it because of poor appetite or is it because of apraxia? All those things you'll have to ask, then only you will know. Then bowel and bladder, sleep latency increase, agreed. So apparently this is not due to vegetarian. So by parietal, what all situations you will consider?
One could be
progressive. It is progressive. No. So it's progressing for 3 years. I have told in some session, any progressive disease, you think, is it degeneration? Is it tumor? Is it slow virus? Always progressive disease, 3 important questions. So it cannot be a tumor in the brain anyway, because patient does not have any raised intracranial tension. Very rarely gliomatosis cerebri, one condition called gliomatosis cerebri. That's an exception, not an example. That does not produce that much ICP. It will slowly infiltrate across hemispheres. It can become bihemispheric across corpus callosum, non-contrast enhancing mass lesion without much ICP. So it can be more posterior. That is there, but that is not the first diagnosis. ICP has not happened even after 3 years. Very unlikely. So it's a tumor is very unlikely. Degeneration, can you think of any degeneration?
Yes, ma'am. Possible. Mostly, maybe like Alzheimer's dementia.
So what will be the classical Alzheimer by this time? Classical Alzheimer starts in the medial temporal lobe. It is in the perforant pathway in the medial temporal lobe. So it will be amnesia. So in our history, that amnesia is not there. So it cannot be a classical AD.
Yes.
Classical AD is amnesic. So far in the history, we have not got amnesia. Female gender is favoring amnesia, but it is not there. So it's not there in the history. So yeah, classical AD is not the first diagnosis. So one thing you can say whether it is a posterior cortical atrophy. There's a condition called posterior cortical atrophy, which is a variant of AD only, but it will involve the parieto-occipital region. Normally, occipital lobe is spared in most of the degenerations. But one condition where the occipital lobe becomes early symptomatic is diffuse Lewy body disease, DLBD. So they present not like this. They will present with visual hallucinations, formed visual hallucinations. So florid, vivid children running here and there. They start like that, they go to psychiatrist, and after some time dementia sets in. That is diffuse Lewy body disease. So posterior features. So it is not a diffuse Lewy body disease because my patient is not having prominent hallucinations. It is not classical AD because patient is not amnesic. It is biparietal. So it can be a posterior cortical atrophy variant of AD. So that is possible. Third possibility, you have got, let us imagine it's an apraxic hand. Other parietal lobe features are not forthcoming. The classical posterior cortical atrophy, other parietal lobe features will be there. Parietal wandering, visuospatial disorientation, getting lost. None of those things are there. So it looks predominantly an apraxic hand. We started on the right hand. Then there is a condition called CBD, corticobasal ganglia degeneration. There, over a period of time, patient will develop cortical sensory loss, myoclonus, extrapyramidal manifestations. So the first possibility, considering only parietal lobe, is it a posterior cortical atrophy variant of AD? Second possibility, is it DLBD? No, because it is not Lewy body, it's not having vivid hallucination. Can it be an evolving CBD? Because it started with apraxia, possible. You cannot say no. So it can it be degeneration? It is very much possible. If you consider degeneration, first diagnosis is posterior cortical atrophy variant of AD. Second, parietal onset CBD. CBD can be 2, anterior type, posterior type. So apraxia is common and it can go posteriorly with the parieto-temporal features, or it can go anteriorly with frontal features. So it can be CBD with posterior features. That is the second possibility. That when you examine, if you find rigidity, tremor, myoclonus, cortical sensor loss, you will think of that. And third, only DLBD, which is just told as a DD, you think it is not at all possible. No? So that is under degeneration. Tumors less likely, very rarely gliomatosis cerebri, because they involve the splenium and go posteriorly. They do not produce ICP. So yeah, it's very rarely. You should not be surprised if you find that. Then you have got the slow viruses. Under the slow viruses, parietal lobe features can be seen in prion disease, hidden Hams variant. There they present more with occipital lobe and minimal parietal lobe. And for 3 years, patient will be dead. So prion disease, just for mentioning, slow viruses, posterior variety is there. There it will be occipital lobe features, and 3 years none of them survive. They die. So very unlikely. So these are the 3 differential diagnoses, among which the first will be posterior cortical atrophy type of AD. Second will be posterior onset CBD, corticobasal ganglia degeneration. We started with Apraxia, it can be a corticobasal ganglia degeneration. These 2 possibilities we will consider and examine. So now we examine. At this point, I will want you to, beetle dementia is very common in Karnataka. No? For some strange reason, beetle maybe the majority are vegetarians. I think so. That's one. But I think they have got some mucosal antibody. I feel so. Many of them have got atrophic gastritis. When we see them and do endoscopic biopsy, they have. So some intrinsic factor defect is operating. Some autoimmune beetle dementia is also common. So that is one you should not forget, but it is a frontal lobe syndrome. Second, pseudo dementias. You should, as an MD student, you should clearly know pseudo dementia versus true dementia, because if you give the label of true dementia to your pseudo dementia, he is going to functionally fail in life. You are labeled and you put him on some anti-dementia drug and he is not going to improve at all. So his quality of life is going to be as much bad as that of a truly demented person. So pseudo dementia is a manifestation of depression. So how are you going to differentiate? That we will use use that to learn. Use this case to learn. So it will be the patient who is complaining. Pseudo dementia, patient will tell, I am not able to remember, I am making so many mistakes. So keeps on complaining. Whereas in true dementia, it is the others who will tell, okay, how many mistakes he is making. But he will say, no, I didn't make any mistake. Only my family members are telling like that. So true pseudo dementia, patient complains. True dementia, others complain. Second, the onset of disease is fairly clear. Patient will tell, for the last 3 months, I am having memory loss. Then it may be pseudo dementia. It may be following some bereavement or something in the house. Whereas a true dementia, the onset is very vague. That is why I told that minor change in the 24 hours routine of the person, which is ignored as physiological, is the beginning of the disease. So it's very, very vague. You don't know when the disease started in true dementia. Whereas in pseudo dementia, 3 months I am forgetting, I am making mistakes. That is pseudo dementia. Then third point, both recent and remote is affected in pseudo dementia. What is your date of birth? I don't know, sir. I am telling you, I am having no memory. Why you are asking all these things? So which school you studied? I don't know. No, which is your best friend in the class? I don't know. So they recent and remote is forgotten in pseudo dementia. Whereas in true dementia, it is the recent memory. That is why the family will tell this person is acting, sir. When his old time friend came, he is so comfortable talking all the old stories very nicely. But telling my younger sister that I did not give him breakfast. You see, so the family will become hostile, but it is true dementia. Recent information is forgotten, remote information is remembered. That is true dementia. Pseudo, both are forgotten. Then I don't know answers. I don't know this, I don't know that. That is common in pseudo dementia. because the person wants to convince that he is helpless. Whereas a true dementia patient, wrong answers. Very happily they will tell wrong answers because they don't know they are telling wrong. So true dementia, going and keeping wrong answer. Pseudo dementia, I don't know answer. Then you give a calculation. There is a phenomena called Ganser phenomena. Near normal. What is 4 plus 3? It is 8. No? They don't make big mistakes. They try to give a wrong answer. So near normal answer they will give. Whereas true dementia, simply nonsensical numbers they will tell. Whereas pseudo dementia, near normal answer. That is called Ganser phenomena, near normal answer. So that is a pseudo dementia. Then other features of depression, like early morning awakening and poor appetite or increased appetite, both can happen. No? And there may be a context which led to this feature of depression. No? So all those vegetative features of depression may be there, which affect the sleep, appetite, and a phenomena which has triggered it may be there. Then we have got in the laboratory, we tell that P300 will be normal, EEG will be normal in pseudo dementia, and in pseudo dementia it is a deficiency of serotonin and other neurotransmitters, whereas in true dementia it is acetylcholine. And you have got some contingent negative variation we call expectancy wave in the EEG. Very easy only. You see, you give a 3-stage command to the patient. Very simple laboratory documentation. You tell, sir, when I am telling you to switch on the red light, you have to press the button there. And if you do not press that button, you will get a shock. That means you have to remember that when the red light is put on, the person has to press the button. And if he does not press the button, he gets a shock. So it's a 3-stage command, which is given at the beginning of EEG recording. Very simple. So you are going to record the EEG, tell first only. Halfway through the EEG, I will put on a red light. When I have put on the red light, you should press that button. If you do not press, you are going to get a shock. So there's a threat involved. No? So a person with a true dementia will forget the command. Okay, so he is very happy. So here the EEG will go on in the same way. Whereas a learned pseudo dementia patient who is going through several tests and wants to convince that he has really forgotten will expect that shock because he remembers the command. He will expect that shock. That produces a discharge in the EEG. That is called the expectancy wave. So presence of expectancy is a very simple method, but not always easy to get it in the routine EEG. You can get it in special EEGs. Routine EEGs can pick it up, but not always. So that is suggestive of pseudo dementia. So beetle dementia you should not forget when he is a vegetarian, and pseudo dementia you should not forget because you retire and you go into depression if you are not getting yourself engaged. No? So it may be, so suddenly you feel everything is gone out of my brain. No? So pseudo dementia is eminently treatable with mood elevators, whereas true dementia is treated with some other medication. You treat that for pseudo dementia is as badly functionally impaired like a true dementia. So these are the things you should remember. And we are thinking our patient has got 2 things, either it is a posterior cortical atrophy type of AD or a posterior variant of CBD. No? Now we will go to examination quickly.
Coming to the general examination, elderly female, conscious, cooperative, well-oriented to time, place, and person. Conjunctival pallor was present, no cyanosis, clubbing, lymphadenopathy, or edema. BMI was 18 kg per meter square. BP was 140 by 80 millimeter of mercury. Pulse was 78 beats per minute, regular with normal volume character, and peripheral pulses well felt. Respiratory rate was 18 cycles per minute, which was thoraco-abdominal in nature. Coming to the nervous system examination, the patient is conscious, oriented to time, place, and person. Right-handed. Attention was normal. Working memory was performed. It was normal. Coming to language, spontaneous speech, comprehension, naming, reading, and repetition were normal. Writing patient, there was normal spontaneous writing dictation, whereas patient was not able to perform this when she was writing, because after initial writing there was change in the way she held the pen and she was unable to complete the task, so she stopped writing. Memory 7-word address recall at 0 minutes. She recalled 6 words. At 20 minutes, recalled 3 words. Remote memory was normal. Visual memory was normal. Coming to the lobar functions, the parietal lobe, visuospatial, constructional apraxia, and clock down.
Mild impairment of recent memory, you could tell. Mild, no?
Mild, okay. This was not done because she was unable to completely write. She was unable to draw the clock.
Okay.
For hemi-neglect, line bisection test was normal. Dressing apraxia was, she had dressing apraxia. Imitation of gesture was not done. However, she had a knowledge of gesture. The sequence of action was not done. Whereas she had the conceptual knowledge and real object use was present. Finger anomia was present. Acalculia, she couldn't do. She was
She
able to
could not
identify.
name her fingers. She could not name.
She could not name, ma'am. She could not. Agraphia was also present. Right-left confusion was impaired. Identification on self was present, whereas identification on examiner was impaired. Graphesthesia was lost. Tactile localization was lost. 2-point discrimination she couldn't perform.
So that means what? Cortical sensations are getting impaired.
Impaired. Cortical sensations are impaired. Coming to the frontal lobe, similarities was normal. First stage palm, she was not able to, as she was not done because she was not able to imitate gestures. Perseveration was present. We did the go no go test, wherein she was not able. There was a perseveration. It persisted, and that triangle followed by square. That test also showed that perseveration.
So
mild frontal impairment. Proverb interpretation and judgment was normal. Occipital visual field was normal, no visual agnosia. Color naming was normal, there was no simultanagnosia, and letter cancellation was normal. Coming to the cranial nerve examination, it was normal, ma'am. Motor system was normal. Sensory system was also normal.
Specifically, did you look for any extrapyramidal?
No, ma'am. I looked for extrapyramidal, ma'am. There is no extrapyramidal manifestation. No tremors.
What is Nokia Froman's maneuver you did? You see, because you have got cortical sensory loss, two things you should specifically look for is myoclonus. Myoclonus is elicited by tapping. It may be a cortical myoclonus, so it may not be spontaneously present. So when the patient is not expecting, suddenly go and tap and look for that. So stimulus induced myoclonus. And then second, you should look, Nokia Froman's is a manifest method by which you elicit mild rigidity. So you tell the person to move the opposite limb. When you are looking for rigidity in the right limb, you tell the patient to move the left limb. Then the rigidity becomes manifest. So you will have to look for mild rigidity because it is important in this case.
That I didn't look for that. That maneuver, I think I didn't do it.
Because this cortical sensory loss is there. Apart from the two DDs we are considering, posterior cortical atrophy and posterior variant of CBD, you are moving closer to CBD.
Yes.
Because in posterior cortical atrophy, you will find visual spatial, but you don't find limb sensory loss.
Okay.
When there is a limb sensory loss, it is more towards the corticobasal ganglia degeneration. So cortical features are there, basal ganglia features you should look for.
Power was normal. Reflexes were normal. There was no exaggerated reflexes. And there was coordination was normal. There were no involuntary movements. Sensory system, cortical sensations were lost. Cerebellar system was normal. No meningeal signs or gait or skull spine carotid abnormalities. Other systemic examination was also normal.
So at the end, what is your MRI is there, no?
Image I don't have. MRI, it was reported as bilateral parietal atrophy with bilateral frontal atrophy.
The films you don't have.
Limbs I didn't put up.
Because you see this, you don't find in the posterior cortical atrophy, you will not demonstrate any cortical sensory loss. The
Okay.
sensory cortex as such doesn't degenerate.
Okay.
The posterior cortical atrophy, it is the post-central and towards the occipital. Those areas become atrophic and the occipital horn dilates. So clinically, you will develop, you will demonstrate other parietal features, but you do not show cortical sensory loss. It is I have never seen, and it is not there also. You don't get cortical sensory loss clinically. When you get cortical sensory loss with proper elicitation, it is not that the patient is looking somewhere and telling, I didn't see. It should not be an intentional error. Really, patient is unable to identify a number, letter, shape, size, and sensory neglect, double simultaneous stimuli mistakes are there, means it is not AD.
Okay.
You don't get it in the posterior cortical atrophy type of AD. And it is favoring a posterior variant of CBD only. So clinically, asymmetry may not be, is there usually, and it will not be cortical atrophy, it will be ventricular dilatation. But there is some mismatch. If you found cortical sensory loss, you are not going to diagnose AD.
Okay.
You will diagnose AD, CBD only. Posterior variety of CBD, you get cortical sensory loss. You don't get it in AD.
Okay.
The posterior cortical variety of AD, you will have all the parietal features. You can have some occipital features also, but you don't get cortical sensory loss.
Okay.
So cortical sensory loss, if it was truly present, it is favoring a CBD. Why is it important? Treatment. You see, Alzheimer's disease still can slow down with cholinesterase inhibitors, whereas there is no role for cholinesterase inhibitors in CBD. CBD almost does not respond to anything. When there is some extrapyramidal manifestation, you can, for a brief period, they may respond to Syndopa. That part. Otherwise, it does not respond to cholinesterase inhibitors. So it's important you double check again whether the patient's cortical sensory loss was due to poor attention. If it was due to poor attention and he was distracted, something like that, in that case, you can say that it is a posterior cortical atrophy. And more, but if it was true sensory loss, you will have to follow up the patient. It may be CBD.
Okay.
Or you will have to do this DOPA imaging and all, that or fMRI, which will show subcortical involvement. Whereas AD, you find only cortical involvement, subcortical not there. CBD will show subcortical involvement. Clinically not involved, subclinically it may be involved. So if there is a cortical sensory loss, we don't diagnose Alzheimer's.
Okay.
Posterior variety of Alzheimer's is not diagnosed. So it may be a posterior variant of CBD only, most likely.
Okay.
So if you are unable to demonstrate it by the routine MRI, you can do the DOPA imaging or you can do the fMRI. Look for subcortical structures getting involved. It's only for academic interest because treatment options are different and prognostication is different. Mainly it is to prognosticate. All these conditions you are going to prognosticate. What is going to be the next? What next? The relatives will ask. Will my patient slow down? Will anything help? So that part, it is of prognostic relevance. And the weight loss, you have to take it seriously. And you will have to look for, but I don't know, paraneoplastic will go on for 3 years, but it can sometimes. No? Because if there is a paraneoplastic neurological syndrome, neoplasm is supposed to be less malignant.
Okay.
So more malignant neoplasms present with metastatic manifestations, whereas low malignant malignancy is present with paraneoplastic. So it may be some small low-grade malignant disease somewhere existing and producing weight loss and paraneoplastic, we don't know. The possibilities, paraneoplastic dementias are there. So, but my diagnosis will be CBD. posterior variant CBD, believing that my patient has got cortical sensory loss. Next time when you present, you bring the image also.
Yes, ma'am.
Then we will see. And some videos can be there so that we will know.
Yes, ma'am.
Okay. Any doubt, ma? See, it's all symptom discussion, DDs. Like that it goes. Tell me, ma. Ask. What did you ask?
Can you just dementia lobe wise, any particular fixed this one, can we have this one? Which dementia will affect which lobe predominantly?
You see, as I told, when there is a dementia patient coming, take the first lobe which is involved.
Okay.
From there, where it is spreading. So let us imagine an amnesic patient. It's starting in the temporal lobe, no? So what kind of memory? Is it episodic memory or semantic memory? So if it is a episodic memory, it is a medial temporal. Semantic memory, it is a lateral temporal. So temporal lobe is a common target. It can be involved in FTD, it can be involved in AD. That is why first you ask whether it is dementia or not.
Okay.
Because language also they will tell dementia. An acute stroke, people will come and tell, my father has forgotten. So first you know whether it is, if it is progressive only, it's a dementia at all. If ideomotor Apraxia is there, to everyone, if ideomotor Apraxia is there, then what?
How she is able to use scissor properly?
Scissors. What is, so that is the classical thing, ma. You see, there will be dissociation. It's a functional circuit failure for one particular task. So other task will be performed. That is a point to diagnose ideomotor apraxia. That's a point in favor. One specific action, they are problematic. In some other action which is needing the use of the same group of activity, they will be doing well. That is the point. That is in fact the point for diagnosis. Some actions are performed poorly, some actions are done normally, which involve the same group of activity. That means it's an action schema failure. Particular motor schema has failed. Other motor schema, holding a scissor is a other motor schema. Whereas clothing and buttoning and making chapati is another. Each one has got a different motor engram. So motor engram for chapati making has failed, but holding scissor is preserved. So that is way in favor of an ideomotor apraxia only. That's a point in favor. So next you first see whether it is memory or not. If it is memory, it is pseudo dementia, true dementia, and if it is true dementia, then go to the other hemispheres. Is it anterior? Is it spreading to the frontal lobe? Is it spreading to the parietal lobe? Is it spreading to the occipital lobe? Okay. If it is spreading to the frontal lobe and it is an event memory, medial temporal, amnesic, medial temporal, and then the frontal lobe, then it may be a frontal variant of AD. It is the lateral temporal, that is semantic, and then the frontal lobe, it may be FTD. Or if it is medial temporal and parietal, it is classical AD. So medial temporal and frontal will be frontal variant of AD. Medial temporal and parietal is classical AD. And medial temporal and lateral temporal and frontal is FTD. Then occipital onset is DLBD. So if it is a cortical. So you have got cortical dementias, only hemispheres. Take the starting hemisphere and look at the rest of the hemispheres. Then you have got subcortical dementias. Under subcortical dementia, you have got Parkinson dementia complex, normal pressure hydrocephalus, small vessel disease, that's Binswanger's disease. They are all subcortical dementias. Here what happens is, they are slow, but they are right. We say cortical dementia, they are quick and wrong. What did you have for breakfast? I took chapati. You would have not taken at all. So quick and wrong answer is cortical dementia. Slow right is subcortical. Then other subcortical features are the presenting feature, rigidity or walking difficulty or spasticity or focal deficit. That comes early and cognition comes later. So subcortical dementia, slow and right, other part of the neuroaxis, not the cortex, they become symptomatic early. There can be asymmetry. So those things are favoring a subcortical dementia, then you think NPH, PDD, then you think of even small vessel disease. Some subcortical butterfly tumors, they can all present with long tract and cortex. So other parts of the neuraxis depending on rapidly progressive dementia, prion, non-prion. So it's a slow prion disease and other non-prion related rapidly progressive dementias, metabolic, nutritional, toxic, traumatic, radiation. No, they are all rapidly progressive non-prion disease. Then if you have dementia with systemic manifestation, like vascular dementias, neuropsychiatric lupus, no? Rheumatoid arthritis, Hashimoto thyroiditis, no? Malabsorption syndromes. So they are systemic malignancies. So that is dementia systemic. So dementia is a vast thing. Each symptom again has got a huge amount of, but grossly you can remember like this.
Yes.
Then every case is different. You can discuss like that.
Any
Other question?
Any infectious causes? Infectious cause for dementia?
Prion, no? Then you have got slow viruses, Jesman's cross, that's also prion disease, no? SSP, dementia in children, no? Progressive rubella encephalitis, no? Progressive herpes is there, HIV dementia is there. They are all slow viruses.
Okay.
Any other question?
How to differentiate pseudo dementia from subjective cognitive decline?
See, pseudo dementia is purely depression related. Subjective cognitive decline, patient feels, as I had made one session on subjective cognitive decline sometime back in our neurology series. So subjective cognitive decline is not having the classical features of depression. And there is some laboratory evidence. And when you do the various test material, there is one standard deviation loss. Whereas in pseudo dementia, clear pattern is there. So subjectively patient is complaining, objectively decline is not noted. You do the neuropsychological test, you find that there is a one standard deviation drop in the test. If it is two standard deviation, it becomes mild cognitive impairment. One standard deviation, it becomes subjective cognitive decline. So that is how you differentiate. Patient claims dementia, other features of depression are not there. There is no other pseudo dementia features which I told. Long recent and remote, I don't know answers, Ganser phenomena, none of those things are there. Patient simply says that I am forgetting many things. I feel I am not as good as before. And other features of pseudo dementia are not there. And then you do the test, you find that there is a one standard deviation. That's an indication to investigate and follow up the case. That is subjective cause. True standard deviation becomes MCI. Any other question?
Question is difference between clumsiness and bradykinesia.
Clumsiness, bradykinesia is only slowness. So you do this kind of test, progressively it will become small. You do repeated tapping, the tap becomes low amplitude and slower. Speed and range becomes less. So bradykinesia, progressive decrease in the speed and the range. Clumsiness is uncharacterized. It can be due to sensory loss, it can be due to mild pyramidal. You are not able to demonstrate progressive decrease in the amplitude and velocity, then it is not bradykinesia. Bradykinesia, progressive decline in amplitude and velocity is demonstrated. Instead, something is wrong. Patient is manipulating, he is clumsy, putting fingers there and here. It can be apraxia, it can be sensory loss, it can be mild motor, mild cerebellar, all those things. They are, when you are not able to demonstrate clear-cut features of pyramidal deficit, they become clumsy because kinetic melody is lost. Early extrapyramidal, they are clumsy. Mild cortical sensory loss, they are clumsy, but you are not able to demonstrate this bradykinesia. That is slowness. What else more?
Which book to refer for a different battery of tests to test a dementia patient?
Different battery of tests, you see, first you clinically assess. I think clinical is best. Then you apply the HMSC. Many mental status and HMSC is there. And HMSC is not paid and it is applied for Indian patients. So apply the Hindi mental status examination. That is a screening tool. By the screening, you feel that a literate person is less than 24 or illiterate person less than 19. Then depending on whatever is, you have got a frontal battery, you have got a Montreal cognitive assessment, or you have got Addenbrooke. So many things are there. Everything you don't have to apply. Then you will spend your lifetime for one patient. You see, there are so many cognitive assessment books, ma'am. I think you should choose for your patient. It's not at all possible to apply everything. First, you have to look at three parameters. One is activities of daily living. Second is behavior. Third is cognition. So after HMSC, depending on which lobe you think is involved, you can take that appropriate assessment battery. You can take Arden-Bruce, which is having grossly a larger coverage. No? Otherwise, frontal assessment is only frontal lobe. MOCA can be used. So that can be used, and you design it based on your patient. Second is for ADL. There is a EC score. It is called EC, Everyday Activity Score. EC, EASY. That is the everyday. So ADL is assessed using EC score. Then behavior. You have got different scales for depression and other behaviors, but just ask questions and find out the behavioral problem. So activities of daily living, how it is impaired, cognition, how much it is impaired, and behavior. If the behavior is the dominant thing, it goes for anterior dementia. If cognition is the maximum involvement, it goes to AD and its variant. If ADL is more impaired, it goes to subcortical dementia. So 3A, B, C, we say ADL, behavior, and cognition. All parameters. ADL is also EC score, very easy. It's a EC score, everyday activity score. You put in the Google and see, you will find that EC score. That can be applied. HMSC and EC score. Then depending on the Arden-Brooks, if you want, you can apply. Or I will suggest PGI battery. Yes, it's an Indian battery. You can use. Postgraduate in Chandigarh, no, PGI battery is there. You have got NIMHANS battery is there. No? So NIMHANS battery is validated for right-handed people less than 65. Now there is a new scoring being studied for people more than 65. That will come out. No? So NIMHANS battery, PGI battery are Indian batteries. You can apply. But remember to look at this. ADL. ADL is the first affected subcortical. Behavior is first affected frontal. Cognition is first affected AD variant, like that.
Okay.
Any other question?
In limb kinetic apraxia, is there mild corticospinal lesion?
No. If it is there, you don't call it as apraxia. If it should not be there, that's an exclusion criteria.
I think
anything else?
That's all. I think questions. In YouTube also there are no questions.
Okay. Thank you.
Thank you so much. In dementia, it is like we don't see so much in depth. Like,
but you presented very well, ma. As an MD student, you presented very well. But dementia is again a vast, like everything in the neuraxis, it is in the vast arena of divinity. So each symptom you can analyze and discuss for one session. So it goes on like that. So every time you discuss, you have to think of God, how He created man. But another question is there, why so much suffering? I don't know. At least if God tells you, you have done all these sins in this Janma or last Janma, so you are given all this suffering, at least we'll understand there is some justification. You sit with a patient every day, that question is there, you don't know the answer. And our own lives also will see that. Why this human birth with so much suffering, we don't know. You see, it's very interesting to analyze, discuss. At the end, it is all the big zero. We tell them zero. Purnamidam, Purnamida. So it's all Samburnam. We don't know what is that. You can keep on discussing and keep enjoying or feeling sad. Both are possible. Okay.
Thank you so much, ma'am.
Thank you.
Thank you so much, ma'am.
Thank you. Then we
It
will
was
meet.
indeed a comprehensive clinical class, ma'am. We could learn a lot from the discussion. Thank you so much, Professor Yasa Chandra ma'am, for your valuable inputs and a wonderful discussion. Thank you so much, ma'am.
Thank
We are
you.
ever grateful.
Thank
today.
you.
Don't
It
feel
was an
grateful. I am
excellent
only grateful.
presentation by Dr. Balaji sir.
Yes, he did very well, like a DM student. He
We could
did
learn a lot from your presentations.
very good.
Yes, ma'am.
Thank you.
I thank all the participants for